So hello everyone and good afternoon. My name is Stephanie Heberle and I'm project manager of ERKNet and are actually organizing these webinars. And we are very happy to welcome today Doortje Reijman from Amsterdam, who will give a presentation on the Lipidapheresis Guideline project, also initiated by ERKNet and ESPN. And together with me, also later, Jens König will join as a moderator and guide this session. I just would like to remind you that you are muted, but if you have questions in the meantime, you're welcome to enter them into the platform, and I will read them out later to Doortje, and she can answer after her presentation. Before we start, I would like to introduce today's speaker. So as I already mentioned, Doortje Reijman is presenting today, and she's a PhD candidate from Amsterdam UMC, and she's performing clinical research on treatment of children with homozygous familial hypercholesterolemia and severe heterozygous familial hypercholesterolemia. The Amsterdam UMC is the hospital with the largest outpatient clinic with children with heterozygous and homozygous FH. One of the topics of her research is lipoprotein apheresis in children with homozygous FH. A specialized treatment with it, which is performed in the Amsterdam UMC for several years now. So, and I think on this topic also, Doortje will now give us an update, and I'm really looking forward to your presentation. Thank you.
Thank you very much for the introduction and welcome everyone. Yes, I'm gonna, as introduced, I'm gonna talk about lipoprotein apheresis in children with homozygous FH, and this is very rare. So, I'm curious how you will find this presentation and if you know already something about it or not yet. So I first want to get to know you a bit and also know what your knowledge is about homozygous FH. So I have a few questions for you, which Stephanie will make available, I think.
Yes, I'm. So now you can vote.
So first I'm curious, where are you from? I think most people are from Europe, but maybe there are also some people from other parts of the country. Then we know in which time zone you are, if it's early in the morning or like here in the afternoon.
So can you see the answers?
Yes, most people are indeed from Europe, but there are also quite a few from Asia, North America, and South America. So we're mixed. There are a mix of attendees. Good.
So we go to the next question.
Yes, please.
Okay.
Yeah, I'm curious what your knowledge is also, so I can adjust my presentation a bit for you. So if you don't know anything about it, please just vote 0. I don't know anything about homozygous FH, because then I will go slowly through the introduction. And if you're an expert, then I'm curious who you are, because I think I know many of the people who are involved with lipoprotein apheresis.
Okay. Do you see the answer?
Yes, so 2/3 is heard of homozygous FH, and that's already a good start, I think.
Perfect. And you want to continue with the next one?
Yes, please. I think I have 2 more questions.
Okay.
And you're all involved. Yeah, what is your experience with patients with homozygous FH? It's very rare, so there are only, not every center is treating these patients. And I'm curious, does your center also treat these patients with homozygous FH?
So I wait another 10 seconds. Okay.
Okay, half of the people don't have patients with this disease, but the other half do, and some even treat these patients. So that's good to hear. Then I think maybe I have one last one, or maybe this was the last one. I'm not sure.
There's the center where you work.
If your center also performs lipoprotein apheresis.
I'll give another 5 seconds. Okay. Just quite close.
Okay. Half of the people have this treatment at their center, and half of them don't. I think quite some people have it available in their center. Over the world, it's not available everywhere, but in Europe, we have the availability is better. So I now know.
One last question, if you want.
Yes.
Can also show this. It's
oh
more
yeah,
about
for adults. I work with children, but I'm curious if you are working with children or adults. Thank you, Stephanie.
Super. So.
Okay. Oh, most of you with children. I thought many would work with adults, but good to hear that many of you also work with children. And then these were all the questions, and I have a good baseline. I know to who I'm talking, and then I'll continue with my presentation. As said, I'll first start with homozygous FH. What is homozygous FH? Some of you already know it, but not everyone. So therefore, I'll just first introduce the topic. Then I'll continue with the treatment of homozygous FH. Lipoprotein apheresis is one of the treatments, but of course you also have other treatments. So I briefly want to discuss which treatments are available. Then, of course, I want to talk about lipoprotein apheresis and the consensus paper. And then there's time for questions from you. And if you have any questions, please ask them, because I like to get questions. So first, homozygous FH, what is it? First of all, it's very rare. It's estimated that only 1 in 400,000 people have homozygous FH. And the heterozygous form is a lot less severe, and 1 in 300 people have that disease. But homozygous FH is a lot less prevalent. It's characterized by extremely elevated LDL cholesterol levels, which can be up to 20 millimoles per liter, and xanthomas, which are cholesterol deposits underneath the skin, as you can see in the photos here. And often this is also the first symptom that children have, and sometimes they go to the GP or the dermatologist, and you hope they recognize it and they find out that it's homozygous FH, but sometimes they don't really know what it is and it doesn't hurt, so they just leave it. And most important is that this elevated LDL cholesterol leads to cardiovascular disease. And one of the first cardiovascular disease which is present in these patients is aortic stenosis. And this is already present often in childhood. So before the statins were introduced, this was already almost 60% of the children already had this at the age of 15 years. And after the introduction of the statin, we see that less people get this, and at an older age. So 40% of the patients has this at the age of 20 years. Of course, there are other major cardiovascular events, and at the age of 30 years, already 1/3 of the patients have a severe myocardial infarction or interventions for cardiovascular disease or even cardiovascular death. And these are all the means or the medians, but there are also cases of children who already die of this disorder at a very young age. So this is a case report of a 4-year-old boy who already died at the age of 4, because here you can see his coronary artery, which is almost fully occluded. And these cases, you hear them every so often. Children of 2, 3, 4, 5-year-old already who die of this disease. So the first cardiovascular disease is aortic stenosis, but other very important diseases, of course, are myocardial infarction and cardiovascular death. And this also makes it really a disease of children. While the heterozygous variant is less severe and people get their cardiovascular disease only in adulthood. And why do they have such a high cardiovascular disease? That's because the cumulative LDL cholesterol exposure gives them this high risk. And if you have a normal cholesterol, you have a higher risk of cardiovascular disease when you're older, like 60 or 70. The patients with heterozygous FH have this when they are 35 or 40 years old, while the children with homozygous FH already have reached this threshold in childhood. And homozygous FH can be diagnosed in 2 ways, the clinical criteria or the genetic criteria. And the clinical criteria are an LDL cholesterol above 10 millimoles. First this was 13, but we do more and more genetic testing, and then we also find the patients with homozygous FH who have a lower cholesterol. And so therefore it's now 10 millimoles, combined with those xanthomas, the cholesterol deposits underneath the skin, and untreated LDL cholesterol levels consistent with heterozygous FH in both parents. And then you have the clinical diagnosis, but you can also confirm this with genetic diagnostics. And then we look at biallelic variants in 4 genes, and these genes are all involved in the cholesterol metabolism. More than 90% have mutations in the LDLR gene. This is the LDL receptor gene. And here, I hope it's large enough, this picture. We know there are more than 1,600 pathogenic variants, and most of them in these 4 genes. And the LDL receptor gene, it's shown on picture A. There you see an LDL cholesterol or an LDL particle, which is taken up by the LDL receptor in the hepatocyte, and then the LDL cholesterol levels are lowered. If there is an LDLR mutation, the receptor isn't working or is only partly working. There you can have 2 forms of a mutation. Some lead to a total null or negative mutation, and then the LDL receptor doesn't function at all. Or there is a defective mutation, and then you still have some activity of the receptor. Furthermore, you have there are mutations in different genes, so ApoB, and then the LDL particle can't be taken up by the liver because ApoB helps binding the LDL particle to the receptor, or PCSK9. And PCSK9 binds to the receptor and leads to degradation. If you have a lot of PCSK9, the receptors are all degraded and can't be used anymore, and this leads to accumulation of LDL cholesterol in the plasma. So it all leads to reduced LDL clearance and therefore high LDL cholesterol levels. And as I said, most of them are in the LDL receptor gene, and depending on which type of mutation, the defective or negative, it leads to a different phenotype with 2 negative mutations leading to a very, very high cholesterol level and early ASCVD in life. So to prevent cardiovascular disease, it's important to start lipid-lowering treatment as early as possible, and this can already be in the first year of life. We start with the treatment target in children is below 3, but many are treating adults. So I also have the treatment target for adults, which is below 1.8. And if patients already have CVD or risk factors, it's below 1.4. So if you're coming from above 10, which is the clinical diagnosis, then you have to lower it a lot before you can reach these targets. And treatment consists, of course, we begin with a healthy lifestyle, including diet and sports, but also smoking, because the combination of smoking and FH is very bad for the cardiovascular risk. And then we have medication, oral medication. The cornerstone of treatment of FH is statins and ezetimibe, which are both already around for many years. And furthermore, there are many new drugs developed in the past years. The bempedoic acid is one of those, which is now in trial in children. And lomitapide is already around for a few years, but is not available either for children. Then there are subcutaneous injections, PCSK9 inhibitors, evolocumab, alirocumab, and inclisiran. This November, alirocumab was approved by the EMA for children above 8 years, and evolocumab was already approved for children above 10 years since I think about a year. Inclisiran is still in trial and is available for adults. So in the future, it will probably also be available for children. And then there's evinacumab, which is an intravenous therapy and was approved by the EMA this week. So there are a lot of new therapies being developed, and now even this year coming available for children. But of course, there's also lipoprotein apheresis. And the mechanism of action is important, because what I said about the residual LDL receptor activity, often these medications need residual activity because in different ways they stimulate the receptor. And if you have mutations which lead to no LDL receptor, these drugs don't work at all or very minimal. So there are a few which are independent of the LDL receptor, and that's also evinacumab and lipoprotein apheresis, and therefore this therapy is still very important. So lipoprotein apheresis, half of you have this therapy available at your center, but not everyone. So it's extracorporeal removal of LDL cholesterol from blood or plasma, and it can lead to a reduction of more than 70% after one session. But the LDL cholesterol levels go up very quickly after a session, and therefore it's often repeated weekly or bi-weekly. So it's a quite invasive therapy if you compare it with just taking oral drugs or having a subcutaneously injection. It's only performed in specialized centers, sometimes by nephrologists and sometimes by cardiologists. That depends per center. So there was an unfulfilled need for guidance in this treatment. As I said, homozygous FH is very rare, with a prevalence of 1 in 400,000. And this treatment is not available everywhere. So worldwide, not many patients are treated, and each center who treats these patients only treats a handful of them, especially if you're only treating children. And therefore we worked on this consensus statement. We made a core work group and a voting group, in total including 40 experts from 16 countries. And these were countries from over the world, so mainly Europe, but also colleagues from Australia and North America worked on these guidelines. And we made PICO questions and answer these with statements, and this was based on the available evidence. But unfortunately, with a rare disease like this, you don't have any randomized controlled trials, so it was only based on observational studies, case series or case reports, and the expert opinion. So we did have a lot of expertise together in this group with 40 experts. And here we had the voting group. They shared their level of agreement, and only if statements had more than 70% agreement, we included them in the guideline. And we had 8 topics: the indication, when do you start apheresis, the methods, which vascular access you use, what treatment targets do you aim for. We also made a topic about monitoring the clinical efficacy. So which imaging do you use to screen for signs of cardiovascular disease. We included the side effects and the role of Lp(a). I will focus on the most relevant topics for you, and won't go into the monitoring clinical efficacy and the role of Lp(a) unless you have questions about that, of course. So for the indication of LA, we had made a diagram. So children with homozygous FH first have to be treated with lipid-lowering therapy and then drug therapy. And as I said, it consists of diet and pharmacological therapy. And it depends per country and the age of the patients with which pharmacological therapy is available. If with this therapy, the LDL cholesterol is above 7.8, which is far from the treatment target, we advise to start apheresis and as early as possible. We know from experience that this treatment can already be started in patients from 2.5 years old, depending on the method used and the body weight of the patient and the experience of the center. There are more factors involved. If the LDL cholesterol is above 3.4 and someone already has ASCVD, we also advise to start apheresis, because then we know there's already a high risk and you don't want that to evolve even quicker. If someone has LDL cholesterol below 3.4 and there are no signs of ASCVD, we consider to start LA depending on other CVD risk factors. So that's here summarized. And as I said, we recommend starting early in life, and that is possible from the age of 2.5, but it's really dependent on different different factors as well. So then we move on to the methods of LA. There are selective methods and unselective methods. The unselective method is total plasma exchange. This has already been used since about 1989, I believe, or 87. And here you remove the blood and take out all the plasma and replace it with a different fluid. And this is not specific at all, so you lose a lot of other proteins as well, and it's not very effective either. And then you have more selective methods. Here you see an example of the full blood method, where the full blood goes through a filter and lipoproteins are being taken out by the filter. Then there are 2 other forms of really where only the plasma is filled. System. And we suggest to use the selective methods. There's not a clear preference for one of the methods. often centers only have one method available, and based on the literature, we don't see that one of the types is more effective or has less side effects. So you can just use the system which is available at your center. But we don't recommend to use plasma exchange because it's not selective and because therefore it gives more side effects and it's less effective. And with these systems, it's possible to use to reach an acute reduction of more than 70%. So we recommend to aim for this, and therefore you do need a good blood flow, and you need to treat enough blood volume. And for the vascular access, there are several options. There is an AV fistula, which is very well known, of course, by nephrologists because of dialysis. Peripheral vein needling is also an option, which is preferred by cardiologists. This is what we noticed during creating these guidelines. You can also work with a central venous line or with a central venous line with port. This is only used by a few treating physicians. So we have the preference for these three because with port is only used by a few people, but you also have to replace the port every now and then. So this is not preferred. It has the pros and cons. Peripheral vein needling is easy. It's ready to use. You don't need surgery, so that makes it patient friendly. An AV fistula is handy because it has a high blood flow, and therefore the apheresis sessions don't take very long, which is handy, and especially for children, but also for adults, of course. It's good to not be in the hospital for a full day every week. And the CVL is feasible in small children, so can be preferred in those children. But the cons, the peripheral vein needling is very difficult in small children with small veins, and it can only give a very low blood flow, and therefore it takes very long, sometimes up to 5 hours, to complete an apheresis session. The AV fistula requires surgery, and it has a potential cardiac burden. And the CVL gives high infection and obstruction rates and has a risk of dislocation. And therefore we say that first you have to see if it's possible to use peripheral vein puncture, but if this is not possible, we suggest to start with a functioning AVF because this has less infection rates and dislocation rates compared to CVL. But most important is you have to discuss this with the patient and the family. We noticed that cardiologists don't even consider an AVF, and the nephrologists don't consider peripheral vein puncture. But we concluded that's good to consider both and pick the most convenient option for the patient. If you use an AVF, it's important to monitor the cardiac burden of the increased circulating volume. And this was mainly the cardiologists thought this was very important. Then we move on to the treatment targets. If you use apheresis, the cholesterol levels go up and down very quickly around the apheresis session. So to calculate the mean LDL cholesterol levels, you have to use a formula to calculate this, including the LDL cholesterol post apheresis and the LDL cholesterol pre-apheresis. And with this formula, you can calculate the mean level, and then we aim for a target underneath 3.0. Which is quite low, but especially if you combine lipoprotein apheresis with the pharmacological treatment options, this can be reachable. If children already have cardiovascular disease, we suggest to consider even lower treatment targets. of below 1.8. But from experience, we know this is very difficult. And also quality of life of the patient has to be taken into account when considering to aim for this lower target. Then this is a lot of text, but with the new treatment, we noticed in our patients that you can reduce the frequency of lipoprotein apheresis. So some patients had apheresis every week, and they could go back to apheresis 1 every 2 weeks while still attaining the treatment target. And this gives them the opportunity to go to school more often. And this is a great extra effect of the new lipid-lowering therapies. So then the side effects, I just want to go through that quickly because, as you can see, many of the side effects are also side effects which you can see when children are receiving dialysis. One I want to light out is the bradykinin release related symptoms, which can cause nausea and vomiting, flushing, tongue swelling, severe abdominal pain, and hypotension. And we see this only when patients are treated with apheresis methods which use negative charged membranes in the filters. So it sometimes helps to switch to a different method to prevent these symptoms. And we also know that ACE inhibitors can make these symptoms worse when they are used and negatively charged membranes are used. So ACE inhibitors should not be used when you use negatively charged membranes because you have a high risk of these bradykinin release symptoms. So then we already move on to the conclusion. This summarizes most of the statements in the guidelines. So children with homozygous FH should first be treated with optimal lipid-lowering therapy. And this includes diet and the pharmacological therapy, which is available for the specific patient, depending on the age and the country where the patient lives. And then depending on the LDL cholesterol reach with optimal lipid-lowering therapy, and depending on if a patient already has ASCVD, you should start apheresis as early as possible, or consider to starting it if the LDL cholesterol levels are higher, but there's no ASCVD yet. And then the vascular access depends on the patient, but we prefer an AVF or peripheral vein needling. You should use a selective apheresis method for which different systems are available. You should aim for more than 70% reduction per apheresis session. And the treatment target is below 3.0 or lower if there's already ASCVD present. Furthermore, just about homozygous FH is a very rare disease with a prevalence in 1 in 400,000, and it can be diagnosed clinically or based on the genes. Clinically, it's an LDL above 10 millimoles, and in the genes, most often the LDL receptor gene has a mutation. Then to prevent cardiovascular disease, of which first is often the aortic stenosis, you have to treat as early as possible with the pharmacological therapy and lipoprotein apheresis when the LDL cholesterol is stays above the treatment target, and is all to prevent premature ASCVD already in childhood. So one more time, early diagnosis is very important, and you have to start treatment immediately, and you have to lower it aggressively to give these children a healthy childhood. I would like to thank everyone from the core work group and the voting group, all these people have contributed to this paper, and it's now in the review process. So hopefully soon it will be published and everyone can use it who's treating children with homozygous FH. And this is already the last slide. If you have any questions, please write them in the chat, and then Stephanie and maybe already Dr. Koenig can ask them. I'll stop presenting. Yeah, there's Jens Koenig already.
Yes, Doortje, thank you very much for this wonderful overview on this indeed very scary disease. I actually don't have access to the questions in the chat yet, so maybe I would need some help from Steph there. Are you around, Steph?
Yes, I can read them.
Cool.
I just have to make it bigger. So the first question, so the first person thanks you for your great talk. And do you do lipidapheresis for conditions other than FH, like for refractory nephrotic syndrome? And does the protocol differ there?
Thank you for the question. I know it's used for other diseases as well, but my research only focused on the treatment of homozygous FH, so I'm not involved in the treatment of children with other diseases. Yeah, so for me it's difficult to answer. I think many parts of the guideline are you can apply those for children with other disease as well. Although, for example, vascular access, we prefer an AVF, but if you only use apheresis for a short period of time, you of course don't want to use an AVF. So there are some things which are different in different diseases.
Okay, thank you. Then there's one other question. Do you have experience with the new subcutaneous or IV drugs? Which one could you recommend being used first?
Yes, the subcutaneous drugs are a lot less expensive. That's important to say. Those cost around, depending which one, but around 2,000 a year per patient, while the intravenous drug evinacumab costs more, thinking of 100,000 or 200,000 a year. So they're only there for already. It's good to start with the subcutaneous drugs. The subcutaneous drugs are PCSK9 inhibitors, and those are LDL receptor dependent. So therefore it's important to do genetics in a patient. If you already know a patient has 2 null mutations in the LDLR gene, then it's not, you shouldn't start PCSK9 inhibitors because it won't be effective. So for those patients, the intravenous drugs are better to start.
Okay. So far there are no further questions, but maybe until Jens, do you have any other questions?
Yes, I would, if I may, I would actually be interested. What is the ratio of a lower treatment target in adults compared to children? I mean, you mentioned that you would use 1.8 millimoles per liter in children who have obvious cardiovascular disease as well, but in the guideline it says that 3 millimoles per liter, and in adults it was 1.8 as well, if I saw that correctly.
Yes, sorry, what was the exact question?
Yeah, why are the treatment targets lower in adults compared to children?
Yes, the treatment targets, that's an interesting topic on itself, because those numbers are not, there's not a lot of literature to base these numbers on. we know from literature the lower the better. So we can say everyone should have an LDL below 1, but of course that's not feasible. For children, we know that the 95th percentile of normal LDL cholesterol is 3.4, and therefore the treatment target before was below 3.4. So that was the reason for children. And now we also know that it's you can reach even lower cholesterol levels, and we know that even in the first few years, children are often not treated, so then they already have are exposed to higher LDL cholesterols, and therefore you want it lower later in life. Adults have an extra risk factor compared to children, namely their age, and the older you get, the higher risk of CVD, especially in these patients. So therefore the cholesterol, the targets are lower in adults.
Okay, but still we're talking about quite a long time of life to go for the cumulative risk in these children as well then.
Yes.
And if I may ask a second question, because we just have that experience. We started one of our homozygous FH patients on evinacumab, and that was quite successful. It lowered the LDL levels by far, and I'm now wondering what is the correct way? Should I adapt the treatment target to lower levels, or should I go straight for extending the lipidapheresis sessions, the frequency? So what is the correct way there? What would you suggest?
Yes, I think that's a very difficult question, and we also had this question with all our patients, of course. If you have a healthy child, you hope they will be healthy and will reach a normal age in a healthy way. So then the lower the better. But for now, I do believe that if you're under the treatment targets and there are no signs of ASCVD, then you're safe, hopefully. So if you're low enough, then I would suggest to try to reduce the apheresis frequency, just because it also makes the children feel less sick if they don't have to go to the hospital every week. And if you can try it, and then if you are still below the treatment target, keep it. And we also explain to the patients we are reducing the frequency, but if we are above the treatment target, we will go back to the higher frequency of every week, for example.
Steph, are there any other questions in the chat?
Yes, I sent them to you via mail.
Oh sorry. I'm a man, I'm not a multi-target here.
Yeah, I could not read it out by myself, therefore I thought it's better if you...
Okay, the question is apparently, does LPA play a role in the strategy, in the treatment strategy, apparently?
Yes, Lp(a), for everyone, it's a lipoprotein A. It's a risk factor for ASCVD. A few years ago, this wasn't a risk factor which was taken into account when making guidelines, but the past years it's becoming more common to include it in guidelines. For children, it's not clear yet if Lp(a) is an extra risk factor. That's still to be established. And specifically in patients with homozygous FH, we don't know that yet. And children with homozygous FH have already a very high risk on CVD, so the extra risk of a high Lp(a) is relatively not that big as you compare with other healthy children. Some treatments do reduce Lp(a) as well, including lipoprotein-apheresis. So yeah, it's not a reason to start lipoprotein-apheresis for the children with homozygous FH, but it may contribute to a lower CVD risk, but we just don't know that yet. We do think it's important to measure Lp(a) at least once in children with FH and also with children with homozygous FH, but we don't. We didn't make clear statements on it for the treatment, just because we don't even know if it's a real risk factor for these children.
Okay.
So there's another question. I can read myself. Don't the different methods of LA affect HDL to different extent, and does this influence your choice?
No, not really. The plasma exchange is, as I said, not selective. So this you do lose HDL with this treatment, but with the selective methods, they're all about they're just as selective. So there's no they're all just as selective on HDL, so it doesn't matter which one you use.
Great. So I see no further questions. So
may
maybe
I ask one last one, a personal opinion, if I may. In the setting of a severe LDL receptor defect with a missing LDL receptor, you pointed out very nicely that PCSK9 inhibitors don't really work. And what's your personal experience in that setting? Have you ever reached a treatment target with just diet and statin therapy?
No.
Never ever. Yeah, because at least in Germany, I don't know how that is in the Netherlands, but we have to treat these patients pharmacologically first for at least half a year to prove that this therapy is not sufficient before we allow to start lipidapheresis. And as you pointed it out very nicely with the PCSK9 inhibitors, they are not able to work. I would be happy if we could start earlier. Maybe with the new medication right now that might help as well.
Yes, yeah, I think it's really bad to withhold a treatment for a patient for half a year just to prove it, because you already know it in advance that you won't reach the treatment target, and then the child is exposed to those high cholesterol levels for half a year without a good reason, in my opinion. Yeah.
Thank you very much once again from my side, and I shut up right now and leave the last words to Stephanie.
Thank you. Doortje, can you maybe share the next upcoming webinars again?
Yes.
Perfect. This is the slide. Yeah, so the first webinar next year will be on an overview of biostatistical approaches in clinical research of rare diseases, presented by Ralf Hilgers from Aachen on the 30th of January. And yeah, with this, I think we can wish you all Merry Christmas, Happy Holidays, and yeah, we are looking forward to see you back next year for these webinars. Thank you.
Okay, thank you. Happy holidays.
Happy holidays.
Thank you very much. Happy holidays.
Bye.
Bye.